Oh my goodness, we were muted the whole time.
We muted?
I was. All right. Okay, hang on. Thank you everyone who let us know. Apologies about that. Why can't I get out of this? Sorry about that. Okay, briefly. Ocular path rounds. My name is Megan. Let's get into the first case. Sorry about that. Here is our cat globe. This patient is an 8-year-old spayed female domestic short-hair cat. That was just a dry run. We're having some people walk in now, so I meant to do that. Um, yeah.
Click that off.
Yeah, yeah, it's fine. Thanks, LT. So this is an 8-year-old spayed female domestic short-hair cat. Clinically, they describe retinal detachment, orbital disease, and subretinal granuloma of the right eye. And here it is on our gross view hemisected globe. We've got our optic nerve back here, our cornea up here. We have this tan mass effect, which is involving the bulbar conjunctiva, the sclera, the orbital tissue, the episclera, and even breaking into the uvea, the adjacent uvea. And this was ventrolateral per our gross exam. And we have a retinal detachment with this tissue paper-like retina detached and sort of waving freely in the vitreal space. So we'll switch to our subgross. That. So we have a very purple cell-dense infiltrate, which is where that tan mass was grossly, involving the conjunctiva, sclera, episclera, orbital connective tissue, and breaking into the adjacent uvea, just like we saw in gross. The cornea is now on our right, and the mass is sort of below us. And all that creates mass effect is not neoplasia, because as we drop in closer, now we're all caught up to where we were. This infiltrate is inflammatory. And what we essentially have here are these, we saw somebody. Hang on one moment. I'm going to drop in a place that I like. I'm not finding one. They are coalescing pyogranulomas. In some areas, it's more admixed macrophages and neutrophils. But a lot of these areas, you can just get cores of neutrophils surrounded by macrophages. If I can find like the perfect one, which maybe I won't. Here's a decent area. So core of neutrophils surrounded by epithelioid macrophages. We've got these coalescing pyogranulomas. There's definitely some lymphocytes and plasma cells admixed. So this is actually an inflammatory lesion. And you may have already spotted one as we zoomed around, but let's focus in on these guys, which are multifocally distributed amongst the inflammatory infiltrate. These are fungal sporangia, which in theory have a double contoured wall, which I don't know if you can necessarily see it on H&E. Theoretically, that's a feature. They basically look like this sort of amphiphilic or so wall, and then this sort of indistinct stippled basophilic contents. Here's one that looks like this, but as we look around, there are kind of some other stages. So if I zoom over this way, for example, we have this little area where there are some smaller little guys, which are almost making this lovely like floret-like arrangement or so, almost as if they're kind of exploding out from a central point. And these guys are much smaller than the sporangia that we just looked at. So these are most likely little endospores. And as you look around even more, there are areas that are convincing. I know there's a good one right down here somewhere. Ah, oh wait, daughter sporangia, maybe. Straight up ruptured. No longer endospores at that stage because they're no longer bounded by a wall. I would say arguably these guys are still endospores then. We have a scent. So yeah, maybe is somewhat indistinct, but a little bit of a wall around these guys. So
Those are not happy about it.
yeah, the neutrophils are excited to be involved in this. So we have an endosporulating organism causing an infection in this cat. There's a short list of endosporulators that could be found in animal tissues. As a brief list for any pathology-oriented listeners out there, Batrachochytrium dendrobatidis is one, but that doesn't look like this, and it's more of a frog thing. You got your algae, chlorella and prototheca, which don't look like this, generally smaller. You've got your Rhinosporidium seberi, which is generally bigger. So that leaves our last one, which this is, which is Coccidioides. So this is most likely Coccidioides immitis, but we can't speciate reliably with histomorphology alone. So just Coccidioides species will do. This coccidioidomycosis case in this cat is most likely ocular manifestation of systemic disease. It is possible that some of these fungal organisms could be locally inoculated and cause local infections, but if you see it in the eye like this, be worried that it disseminated there from as part of a systemic infection. And indeed, a piece of history that I suppressed for this animal is that they report a positive valley fever test. They don't tell us what test they did, probably titers on the blood, but they could have done other tests. And indeed, valley fever is another name for coccidioidomycosis. Not Rift Valley fever, confusingly. Rift Valley, different thing. This is just valley fever. Oh, yeah.
And you know by the FELV status of this cat?
Good question. So the question was, do we know FIV, FELV status in this cat? They didn't report anything about it. But yeah, it's a good question to ask if this animal was immunosuppressed with a fungal infection like this. Yeah, the comment was almost never see it in cats that aren't immunosuppressed. Yeah, they at least didn't tell us one way or another, so could be. And then location, we typically see this in the Southwest United States. So this patient hails from Arizona, which fits is kind of the common
That
location.
answered Dr. Debusic's question.
Oh,
Maria is chiming in here. She said, I think I mentioned this before, but Florida has a panfungal PCR.
yes.
They require a GMS to go with the sample.
Yes. So if you need a species of fungus for a formalin-fixed paraffin-embedded tissue, there is the panfungal PCR at Florida. It is not perfect. Definitely, ideally, you have like a good number of fungal organisms in section to get a good result. And with the PCR, you always have to match with morphology. In this case, I didn't recommend the panfungal PCR because it's pretty much slam dunk for at least Coccidioides species, and knowing what specific species of Coccidioides it is probably won't affect their treatment plans or prognoses or anything like that. But yes, if you do want a specific species, a particular species of fungus, that test is available.
And the nice thing is that they try to look at the morphology
Right.
Yes.
and weigh in on their PCR results and whether they make sense or not.
Yeah,
Yeah.
that's why they asked for the GMS to go.
Exactly, hence the GMS. Pathognomonic morphology. Any other questions or comments? Okay. Here's written diagnosis. Okay, so the next case, I'm trying something a little bit different because the actual gross and histology of our actual case is kind of unimpressive in a sense. I don't know about unimpressive, maybe just short to describe is a better way of putting it. So we're doing a little bonus leading into our case. So this is not our case. Neither of these photos are our case. As our bonus, this is a gross image of a rabbit. You can see very swollen and hyperemic lids and conjunctiva and a very cloudy cornea. And on the corneal surface, you have this thick mucoid clinging white discharge. So that's our gross view. And then here is a histologic view of a cat cornea. The stroma is down here. We're totally missing an epithelium. This is an area of ulceration. In the stroma, we have these lovely pink granulated cells. So these are eosinophils infiltrating the stroma with this bright eosinophilic material over the top of this tissue, which probably involves eosinophilic basic protein, at least. And this gross and histologic presentation is pretty pathognomonic for a certain entity, especially seen in rabbits and cats. This is an example of eosinophilic keratitis, conjunctivitis, or keratoconjunctivitis, depending on what tissues it affects. Supposedly a disease of immune dysregulation. In Coplow, we most often see it in cats and rabbits. In cats, there is a connection made to herpes virus infection, but it's not true. It's not clear whether it is a causative relationship or just a correlation. So there is our quick bonus because I didn't have anything else to show you for gross. Now we'll get into our actual case. We can have like a vote as to whether that was a useful thing to do or not. So the actual case is a 7-year-old spayed female German Shepherd. They describe exophthalmos with extremely hyperemic / hemorrhagic and thickened conjunctiva surrounding the eye, corneal ulceration, and CT found a mass-like lesion surrounding the eye and going into the orbit. They described that during surgery, this was a very vascular mass. They had to use a lot of cautery and ligature, and they asked us to read this one ASAP because they were worried about cancer and wanted to know if they should start additional treatments quickly. I don't have a gross, but in an attempt to paint you a picture, the formalin-fixed tissue for this was extremely thickened, swollen periocular tissue, conjunctiva and orbital connective. It was reminiscent to me as if you were to take a thick slab of steak that was frozen and pan fry it. So like parts of it are like pink and it's like both soft and like hard at the same time. I don't know if that paints you a good picture, but that's how it was to me. Very, very abnormal, thickened periocular tissues. So I just used a food analogy. I'm so sorry. And the entire group is not pathology oriented necessarily. So in any case, that's what it reminded me of, I guess. You can tell that I'm not necessarily a great cook all the time. Let's see. So we're gonna start with the globe. So I've already put the globe into our stage, and the cornea is facing to our right again in this case. Briefly, while we were back here in the orbit, you can see exactly what they were talking about with the surgery. They had to use a lot of cautery and ligature. This sort of hyalinized look to the tissue, brightly eosinophilic, kind of losing detail, is pretty characteristic of cautery artifact. So yes, a lot of cautery used on this bloody tissue. Moving back up here, look at how congested the conjunctiva, episclera, and orbital connective tissue are. So much large, dilated, blood-filled vessels here, extremely congested, edematous and hemorrhagic tissue. You can see the hemorrhage between the vessels here. As we walk across the cornea, here's kind of maybe where the edge of epithelium is. We'll drop in to be sure of that. But long story short, very broad corneal ulceration, cellular infiltrates in the cornea, peripheral vascularization with these big dilated vessels in the stroma. And then over here, as we dive down into the orbital connective tissue, we have some muscle over here, so we know we're kind of in extraocular muscle, orbital connective tissue sort of a zone, and there is this really cell-dense infiltrate in here. So lots of purple where it shouldn't be. We'll briefly come back to the cornea just to prove to you that it's ulcerated and severely inflamed. No epithelium, tons of neutrophils, probably some edema in the ulcer bed. But the main event is over here. Back to where we were. Here we go. Where there's relatively less cautery and manipulation artifact and the cells are intact, we can zoom in and see who these are. And your hint was in the bonus case because these are eosinophils. So many eosinophils. All these little polymorphonuclear cells. It's actually easier to see through the eyepieces, but hopefully it's still visible by camera. We've got these pink cells with segmented nuclei, so many of them. There are maybe a few macrophages in between, some of them with a little bit of hemosiderin. You can see hemorrhage in the tissue. Hemorrhagic edematous tissue infiltrated by a ridiculous number of eosinophils. Briefly, we'll throw on some more of these orbital sections. We just had a bunch of pieces of orbital tissue. Wah! Here is a nice section right here. We have some fat right here with these lovely punched out clear adipocytes. They're almost being individualized in some cases by this really cell-dense infiltrate, and it's similar over here with the muscle myocytes being almost individualized amongst a sea of infiltrating cells. But those cells at this location are also eosinophils. So many eosinophils, sheets and sheets of them. And you'll notice that as we keep looking through these too, these are well-differentiated eosinophils. They are not showing any signs of atypia or anything like that. And we can do at least one more random section. More cautery artifact, as you can see. So this one, for example, is another good one showing really severe infiltrate in the muscle and proving to you once again it's pretty much just hemorrhage, edema, and eosinophils. That's what we've got. This would have been a good case for Valentine's Day, maybe a lot of red and pink. We could have just landed on that while we talk about this case. The other thing about this case, we kind of came back to the clinician and asked for more information. They did find on CBC a profound eosinophilia in this patient, like basically one of the highest eosinophil counts they had in the peripheral blood in a long time, sort of a thing. So this patient was an interesting case. Pretty much we just have eosinophilic infiltrates. So your differentials in a case like this could be, is this just purely an inflammatory population, at which point eosinophils would denote most typically a hypersensitivity reaction or response to parasites. So some sort of parasitism, maybe insect bite hypersensitivity, or maybe an actual parasite somewhere in the tissue that we didn't quite catch. Although certainly eosinophils are not specific to these two possibilities. The other thought for a really eosinophilic rich infiltrate in tissues like this, there is something called hypereosinophilic syndrome, which is basically where you have an apparently non-neoplastic population of eosinophils in the peripheral blood and sometimes infiltrating organs. And then eosinophilic leukemia is also a possibility, which is essentially a neoplastic population where a lot of eosinophils are being produced. In the latter case, you would tend to get some sort of other blood work abnormalities, though, like anemia, basically a signal that the bone marrow is being eaten up by these abnormal cells, which we didn't necessarily have in this patient. So basically just some thoughts on this really unusual presentation of really severe eosinophilic infiltrate. But then the clinician followed up on this case a little bit later. After that, this patient was referred to internal medicine. And on recheck, the blood work actually showed the eosinophils coming back down to normal in the blood. So now what this implies to me is that there was some sort of local periocular stimulus for this infiltrate. So most likely differentials of local hypersensitivity or maybe a parasite embedded somewhere that we missed are probably the highest on our list. Having pulled this case for rounds, I did dig through the remaining wet tissue really, really carefully to try and see if we were finding a worm anywhere. And sectioned in anything remotely curious looking, but I am doubtful that we'll find anything. And this case is still somewhat of a mystery at this
Where's that
point.
from?
New York.
Okay.
New York, New York. Not New York, New York, just New York. Anyway, you have a...
Why wouldn't the surgical site, the trauma of surgery result in shifting of an immune response away from a Th2 mediated to a Th1, Th17 mediated one? There's a reparative response, and that can actually shift like all of the cytokine signaling just in response to that trauma.
Interesting. So the comment was that the surgery itself may have shifted the type of immune response that we're experiencing here. It's interesting, yeah. I mean, they are hopefully still working this patient up for like other differentials, including hypereosinophilic syndrome and such. So yeah, still kind of a mystery. By the way, we did also do a toluidine blue on these sections just to rule out the possibility of like a mast cell tumor with like more eosinophils than, neoplastic mast cells, which would be extremely unlikely, but we did check. And there are a few mast cells here and there, but they're well differentiated. So it's not a mast cell tumor, in case anyone was wondering.
That's a good point, because especially in horses, we'll get some conjunctival periocular mast cell tumors where the vast majority of the cells are eosinophils. And then you do a double and you find, well, the amount of cells, it's kind of hard to judge, but you'll find a significant number of mast cells, and some of them have some degree of pleomorphism.
Yeah.
Not super pleomorphic, but
At least like not quite, well differentiated. Yeah. So it was worth a check, but we didn't find anything that looked like neoplastic mast cell population.
Very cool case.
Yeah.
Very weird.
Weird case. Maybe we didn't need the bonus case in this case, especially with the false start. But anyway, I'm going to shift and we'll do the next couple.
Dr. Miller.
All right. Good morning. I have the next two cases for you. First up is this case is we got a nice clinical photo from a 9-year-old lab poodle mix, male neutered, who comes with the history of being diagnosed with a squamous cell carcinoma in the right maxilla and underwent radiation treatment in August of 2024, and then again in April of 2025, and is currently on Palladia. The reason for the visit is this corneal perforation here, which they noted on their findings with iris and fibrin plug kind of prolapsing. So this is a nice little picture of that. There is also absolute keratoconjunctivitis sicca in this eye, and they diagnosed a late immature cataract with intumescence. They did say that the left eye was mydriatic with an incipient equatorial cataract and a normal fundus. There was no glaucoma in this eye. And let's see, grossly, we did say that the globe was slightly collapsed. And we saw the corneal perforation, said it was slightly leaking and partially plugged with tan material, and that we noticed that there was some anterior synechia to the perf, so some iris prolapse. So got some nice histology stuff to show. I don't have a subgross per se. The corneal perf was a little bit off-centered, so we did a regular DB cut, dorsal ventral cut, as we usually do, and our perforation ended up in a different section. So we often do like little banana type sections of the cornea to sample lesions when they're not quite in the plane of section, or will be easier to sample with a larger globe. So here is our cornea here. And here we can see our iris is being anteriorly displaced and kind of contacting the back of the cornea, or what used to be cornea here. So we have this area of ulceration with stromal loss that goes all the way down to Descemet's membrane. So we have a desmetocele here. And then we can see that Descemet's membrane is discontinuous. So there is consistent with rupture, so ruptured desmetocele. And we can see lots of fibrin in here. And we can see that our corneal epithelium is being hyperplastic and is growing over our fibrin. And so in this section, I believe it actually went all the way across. So it's kind of re-epithelialized over the defect here. Again, with our iris stroma coming in and attaching to this material in the perf, trying to plug it up and keep it intact. There's just a little bit of neutrophilic inflammation in the rest of the cornea, kind of leading up to that perforation. The other thing to note is that if we come out here into the limbus and we follow the cornea epithelium out into our conjunctival epithelium should be, a couple layers thick, and there should be goblet cells. But this epithelium has lost its goblet cells. It's actually composed of stratified squamous epithelium that's probably even keratinizing a little bit. So this is some epithelial hyperplasia and squamous metaplasia of the conjunctival epithelium, which would help support their clinical diagnosis of KCS. Kind of a secondary lesion from that can also be caused from exposure, although we didn't think that the globe was ophthalmic in this case. And then moving back to our globe, again, like I said, the perforation was kind of paraxial, so it was not sampled in our DB cut. Again, we can see our squamous metaplasia in our conjunctival epithelium. A little bit of inflammation, a couple blood vessels coming into the peripheral cornea. Got a little bit of edema fluid. And then the other big thing in this case is the lens. And so if we follow our lens here, we can start to see that our lens fibers are starting to get a little bit liquefied. If we get a little even closer, we can see here's our posterior lens capsule, thin area, and we can see this posterior migration of the lens epithelium, which is the earliest stage of cataract formation, as well as our lens fiber liquefaction. We got little rounded up globules here, so our more ganglion globules, and we either have a couple that have maintained their nuclei here, so some bladder cells as well. And so these degenerative findings were present kind of circumferentially in the lens here. So mature cataract based on our section that we have here. And then the retina itself was kind of artifactually detached. There's a little bit of surgical artifact. I think it was kind of clamped really close to the optic nerve, so we didn't really get much optic nerve to look at. But the optic nerve head and the rest of the retina, we can still see layers, still see retinal ganglion cells here as well, which they did not report glaucoma in this case. So interesting to find a nice normal retina and optic nerve, at least optic nerve head in this case that had radiation. So with radiation damage, you can see a lot of these findings that we're seeing here. You can get some early or acute radiation damage that kind of targets the cells that are highly proliferative, like those at the limbus, as well as the lacrimal glands. So you can get blepharitis and keratitis, and even start to develop KCS. For more long-term, kind of later chronic radiation stuff, the KCS can be pretty progressive and irreversible. You can also get cataract formation, which we have here. And in some cases, you can also get a retinopathy and optic nerve disease as well. So we did not get the third eyelid in this case to kind of assess the gland for changes with the KCS, but it sort of goes with the radiation damage from their treatment from the maxilla squamous cell carcinoma. And then KCS probably leading to ocular surface disease and the ulceration and then eventual perforation of the globe. Okay. That was what I was going to show for this one. So, yep, radiation treatment, the KCS, and then the corneal disease and the squamous metaplasia in the conjunctiva and the cataract formation. Okay. So the next one I have is a kitty cat. So this is a 4-year-old female spayed Sphinx cat. This is the left eye on ophthalmic findings at the clinic. They said the globe was ophthalmic, that there was severe swelling of the temporal bulbar conjunctiva with diffuse corneal edema and hypopyon. They were unsure if there was glaucoma, but they reported an IOP of 12. The other eyes they said was not normal, and they suspected anterior segment dysgenesis in that eye. But grossly, this is our hemisection view of the globe. It's a little bit kind of tilted and distorted because it's ophthalmic. Our cornea is here, is very opaque and cloudy. We can see the bulge here at the limbus, like they kind of described. We saw one that was dorsolateral and kind of a more subtle one that was ventral medial, grossly. And then on hemisection here, we can see our iris and ciliary body on this side. It's got this white tissue appearance here. There's this cloudy gel in the anterior chamber that's bulging out here, kind of pushing the sclera. And then it's also completely taking over the vitreous as well. So a solid opaque gel, which made it very hard to see the retina and the optic nerve in this case. So hopefully this might be sending off little bells, little red flags. This gross appearance with this cloudy gel here.
How old was it again?
4 years old. 4-year-old. Doing all right. Here. All right. So we look at our subgrowths here. We've got cornea up at the top. You can see our bulge at the limbus here. And all that cloudy opaque gel histologically is this bright hypereosinic fluid. Again, here in the anterior chamber and then all in the posterior chamber and vitreous and even sneaking here underneath the retina. The other big thing that we can tell, the mass effect, it seems pretty evident on the entire anterior uvea. It's very purple, so quite hypercellular. There's also these areas of kind of pallor and eosinophilia, which is more likely either more of that proteinaceous fluid and or necrosis. Let's take a closer look here. All right. So I've got the cornea on the left, just to be different from Megan. So we can see the hypercellularity here in the anterior chamber or in the anterior uvea. We've got it extends out into the limbal sclera here, causing the bulge. We'll go over this side. We can see that it's expanding and effacing the ciliary body. Here's some squished plica. It's free in the vitreous. Comes back not quite as florid in the choroid, but there's a little bit of cellular infiltrate here as well. So if we go closer and look at the cells that are making this up, we're going to try to rule out or figure out if this is a neoplastic population or an inflammatory population. And as we get closer, I get it in focus here, we can see that it is a mixed cell population. So we have a lot of these segmented neutrophils here in a sea of these larger polygonal cells with these big nuclei and prominent nuclei. So these are macrophages. So we have a nice pyogranulomatous inflammation in here. There is also some plasma cells with these eccentric nuclei and these little clear zones, perinuclear clear zones, and then some smaller lymphocytes in the background as well. So a pyogranulomatous and even lymphoplasmacytic inflammation. Again, like I said, mostly in the anterior uvea, but it does sneak back into the choroid. So it's a little bit of a panuveitis as well. And the inflammation kind of falls off into the vitreous and the spaces where it's accompanied by some fibrin and a lot of this high protein eosinophilic fluid. There is a little bit of cataract formation in this cat. Whoop. Whoop, but not there. Here we go. Here's our posterior migration of our lens epithelium. So a subcapsular cataract in this case. The retina and optic nerve, like I said here, it's a little bit detached with more of that high protein fluid underneath it. And there's a little bit of kind of a similar cellular infiltrate in the retina, some neutrophils, lymphocytes, plasma cells kind of scattered and perivascular here. So in a youngerish cat with this high protein fluid, this pyogranulomatous and lymphoplasmacytic panuveitis, do we have some differentials or something that might come to the top of your list that you might want to rule out in this case? Students who are in the room. FIP, yes, feline infectious peritonitis. That would be a great thing to rule out in this case. And that was the suggestion that we gave to them based on our appearance here. We do offer immunohistochemistry through Cornell University for FIP. It's nice when it's positive, but a negative result does not rule out FIP. And then there was, just to close up their concern for anterior segment dystenosis in the other eye, there was just so much distortion of the angles in this globe from the buophthalmia and the inflammatory infiltrate that it was really hard to sort of give them any sort of clue if there is any sort of malformation in the angle in this case here as well. So no overt microorganisms, pyogranulomatous inflammation. You also consider infectious diseases, kind of like Dr. Kleiman's case, but there was no pyogranulomas in our case. Not that you necessarily need to have pyogranulomas for an infectious disease. No neoplasia, no congenital abnormalities that were obvious. And so suggested that they should try to rule out FIP in this case. We did offer the IHC and did ask them that if they did any other like clinical testing on this case, that we would very much like to know their results, but haven't heard back. So
You'd think in this case that the testing would be like reasonably rewarding. It seems like with more macrophages, you'd be more likely to get a positive result.
yeah, so yeah, the IHC targets the macrophages, and with a lot of macrophages, especially a lot of them kind of free in the chambers, that's where we've had our most success with getting good positive results from that. So this would be a good one if they were interested in sending off to have it. So
Mechanistically, it's a vasocentric disease in other tissues. It's like it's problematic in lobes.
yes,
Yeah.
There are
yes,
a lot of vessels in the uvea.
Yeah.
The
Yeah.
whole thing is one big vascular structure.
yes.
That's
So
what- yeah.
yeah, so the comment was that in a lot of other organ systems in cats with FIP, the main histologic lesion is like a vasculitis that the inflammation is focused on, and we don't always catch that in the globes, but
Almost never.
like almost never, very rarely, if at all. But the other comment was that the uvea is a very highly vascular tissue, so it just, with it being a face like that, maybe we just can't tell that the vasculitis is there. But
I mean, for what it's worth, the only times that I've really seen vasculitis in FIP cases is like retinal vessels, like things made
retinal
of-
vessels with vasculitis, very rare occasions. But yeah, that was not present in this case. So
Yeah, the paper that published, I forgot the specific name of the paper, and I forgot everything with the paper minus the fact that they described positivity being in macrophages almost exclusively, and they proposed the fact that the macrophages with the antigens were coming from elsewhere. There was not a lot of antigen deposition in the eye itself. They were not only in macrophages, but macrophages free floating in the chambers. There was almost no positivity in the uveal tissues or other tissues in the eye. Might explain why we're not seeing the vasculitis, but it's an interesting presentation of the
I
eye.
think there's something about the tissue tropism.
Yeah.
Outside of
Yeah, and what that implies is that for pathologists out there, if you're going to suggest IHC in some of these cases, the more exudative ones with free-floating macrophages are the ones that are more likely to be positive. Sometimes we get a few of those where they have a suspicion of FIP, but inflammation is mainly uveal and lymphoplasmacytic. Just be aware that that might not be a good candidate for IHC.
Alrighty, next up. We have an eye from a 4-year-old French bulldog. It came with a history of corneal rupture and crushing trauma, period. And they say upon enucleation, a large black mass was noted around the optic nerve and extended into the caudal orbit. Their differential was necrotic tissue hemorrhage versus melanocytic neoplasia, which is common grossly and apparently surgically when you can't differentiate between an actual melanocytic neoplasm, which is very dark brown, and hemorrhage, especially older hemorrhage when it's more organized, which can also be very dark brown. So the crushing trauma happened about a week ago, and then rupture occurred today. I'm assuming they meant the corneal rupture.
Do we know what trauma?
No, they didn't tell us any more than that.
Guys out there, please, we are very curious people.
Yeah.
If you know what happened, let us know.
We always love to know. So here is a photograph of the hemisected globe. The cornea is at the top, believe it or not. The brighter white here is the sclera, and as you follow it around, it suddenly becomes discontinuous. And here's some very dark brown tissue that's extending both in it's in the eye, extending through that scleral defect and around the optic nerve, which is this thing here. These are some extraocular muscles that are still attached. And so we noted that there was a broad axial corneal perforation that was plugged with opaque tan material. I think it's not in this plane of section. And unfortunately, I ended up not actually sampling the corneal lesion, but I still believe it's there. I think there's a lit. Never mind. I don't want to lie. So. So I got 2 levels of this globe. And I should have gotten more. I should have gotten step sections and I didn't. But anyway, so here's the globe. The cornea is on the left. And as you can see, it's discontinuous, and that's actually a sectioning artifact. And then when we move back, the inside of the globe has a lot of pink, bright red, slightly orange material in it. And this cavitation that is here is actually also an artifact when it was processed and paraffinized that often can sort of shrink. Some tissues can shrink away from the surface of the block so that when they cut through it, they're actually not sectioning all the way through the tissue. And then as we move back, here's the optic nerve. So we get it sort of in a tangential cross section here. Here's one end of that sclera, and the other one is right here. This brown stuff here is uveal tissue that's prolapsing through that pretty extensive scleral defect. And then over on this side, we have hemorrhage and more uveal tissue. So we have a scleral defect with extrusion of the uvea.
Never good.
Yeah, never good. That's pretty consistent with pretty severe crushing trauma that causes posterior scleral rupture and then extrusion of intraocular contents. So as I said, we didn't actually sample the corneal defect, but here on one edge, we can see that here's Descemet's, here's this corneal surface, and we have the epithelium sort of growing down at a bit of an angle to the corneal stromal fibers. And that is an indication that this is an area of stromal loss with some at least vague attempts at reepithelialization. So as I said, I didn't actually get to sample the corneal defect in the deeper section either. But so as we walk back, so here's the limbus. We can see that here's the peripheral corneal stroma with some blood vessels growing into it. This line of pigmented cells is characteristic of most limbuses in dog and cat eyes and other species as well. And then so we have corneal stroma on one side and we have scleral stroma on the other. And normally what should be here is the iris and the ciliary body, and we just have nothing. And as we walk back, there should be some ciliary body leading into the choroid. And oh, finally we get here where here's some uveal tissue. So this is choroid, and you can see where it is separated away from the sclera. The other side of this globe is also very similar, where there's the limbus. We can do this at lower power here. And then so here's sclera, and once again, we should have some anterior uvea that's attached. And instead we don't. There's no sclera, there's no uveal tissue attached here. This is a little bit curled up segment of Descemet's membrane, which has been torn away, well, presumably Descemet's membrane, which has been torn away from the posterior corneal surface. So whenever we have the avulsion or tearing away of the ciliary body in the globe, we call that cyclodialysis. So cyclo refers to the ciliary body, dialysis refers to separation. And so in this case, I think we might want to call it uveodialysis. I'm not sure if there's actually a great term for this, but and it's almost
Restoration.
yeah, restoration. What was Right, uveitis, yeah, I don't know. And it's almost complete, so near complete uveidialysis or whatever. So here's some ciliary body stroma here. We've got some ciliary body plica. Here's the actual iris. Here's the front of the iris. Here's the back of the iris. Here's some basement membrane, which could either be Descemet's membrane or the lens capsule. I think it's actually the lens capsule. In the deeper section, yeah, it's quite thick. And thick, this is too thick for Descemet's membrane. And you can see that we have one part that's quite thick, and then we have one part that's quite thin. It's all convoluted, so that's good for lens capsule. So the lens was extruded into the posterior, into the orbital space as well. We did not sample the optic nerve in this section, and we didn't actually sample any more of the lens material. So hopefully it's not still in the orbit because it's quite antigenic. But anyway, so that is a nice example of posterior.
So what you know about ocular anatomy, the iris shouldn't be touching the optic nerve.
Yeah. Here's the deeper section where I asked them to get a complete section, hoping that we would actually get the corneal perf, and now I understand that that was a problem in asking for that. So they got me a complete section, and so now we get all of that juicy hemorrhage inside the eye, or not so juicy. It's probably a bit dry at this point. And then here we are back in the orbit. So there's the lens capsule again. And it's somewhat chronic-ish, subacute to chronic, because we're starting to get a lot of this sort of plump spindle cell proliferation, so which is probably in part growing out of the uveal tract. So we've got granulation tissue forming here around that prolapse tissue. Let's see here. I think that was the majority of the things to show here. So I will go ahead and go back to the PowerPoint so that I
Now it will be even more interesting knowing what happened because it looks like such a
yeah
high energy
Yes,
blood
seriously.
or
yeah
penetrating
yeah
blood trauma.
The eye just like inverted itself like a starfish.
yeah it really has. Anyway, so these were my morphs, and some of the stuff I didn't get into the specifics of. Anyway, I did see peripheral breaks in Descemet's membrane, which is what we see with blunt ocular trauma. So the trauma is distributed sort of peripherally, and for some reason it causes peripheral breaks in Descemet's membrane, which we had a nice example of here. So yeah, this was a beautiful case, unfortunately for the dog, of what happens when you have severe ocular trauma. Blunt trauma. Anyway, okay, cool. Let's,
Question on that?
yeah.
So just thinking of it. So say I was back in clinical practice and I was out in my first couple of weeks of practice and I saw this dog that had been hit by a truck and whatever happened, but the owner didn't want to enucleate the eye. What should I tell them about like the expectation for this posterior rupture? Say that I was able to actually throw an ultrasound on there and see that there's a whole bunch of stuff that just goes where it should, into the orbit and stuff.
So the question was, what should a veterinarian tell an owner of a dog that has suffered some sort of trauma like this with posterior scleral rupture? Let's say you were able to confirm that, and what should they expect? I mean, eventually the eye would, the hemorrhage would eventually get cleaned up to a certain extent. No, I would assume the eye would undergo thesis and sort of atrophy. So thesis bulbi would be the resulting lesion there. It would probably be relatively okay, except maybe for the lens, that would be a continued possible source of antigenic and like inflammation and pain. Yeah, so I think thesical eyes can be painful. And I don't know exactly where that, sometimes they're quite comfortable, but sometimes they can be painful. I think it's a very individual thing, and it might be specifically dependent on what the actual, yeah, what led to it, and et cetera, et cetera. So obviously the eye's blind. So there's that. Other than that, I don't know. And as long as the other eye remains sighted, then obviously prognosis for vision is good. If there was enough optic nerve damage back to the chiasm, you could potentially have visual issues with the remaining eye. Does that answer your question? Cool. All All right, this next case is kind of weird.
There are a few things here. So
No.
Dr. D said we have a lot of thecal eyes with collateral rupture. They're quiet but blind.
Quiet.
Quiet but blind.
Yeah.
And Taylor said a case that underwent thesis bulb by eventually was comfortable, ended up enucleating later, and it landed with third eyelid prolapse, and the owner didn't like that. So
Yeah, that's true. When you have a shrunken globe, you don't have normal tear film distribution. And so you will often end up with corneal and or conjunctival inflammation and disease that's sort of consistent, like constant, because you don't have that normal wiping of the ocular surface with the third eyelid and the eyelids and such. So that can be a long-term complication.
Interesting to hear. Yeah, I would think that the lens would still be an issue too, but maybe
Yes.
this resorbs eventually.
right. Yeah.
Maybe it's all case dependent.
Fibrosis around it. Yeah, I wonder what happened to this one. I mean, it could still be somewhere in the orbit. I mean, in the tissue that we received. I don't know. Anyway, okay, cool. Let's try to get through my final case here. Okay. This is a cat. It is a hold on, wait for it. 4-month-old cat that came with a history of evaluation of her eyes after being found outside. So when she was initially found, she had maggots in both eyes. But since then, obviously she kept both eyes. Since then, she has developed multifocal white subconjunctival lesions in both eyes. They have not responded to a month of prednisolone acetate, topical, ophthalmic antibiotics, and also systemic antibiotics. So the clinician did snip biopsy of the affected bulbar conj from both eyes and sent them both to us. So here's a clinical photo of this cat. So I tried to blow it up, but then it just got really blurry. So then I made it smaller again. Anyway, you can see these multifocal sort of pale pink to white foci on the anterior surface of the third eyelid in the medial canthus, kind of conjunctiva, and then the palpebral conjunctiva of the lower eyelid here. The other eye was also affected, but we can't tell in this photograph. So anyway, let's jump right in. This was kind of an interesting case.
Someone's asking where's the cat from? Or you want to hold that information for?
No, it doesn't matter. I can tell you. Pennsylvania. So we got one tiny piece of tissue from each eye. We submitted it intact. From this magnification, we can see the conjunctival epithelium on the surface that goes almost all the way around. And then the stroma is quite busy. So we've got some darker purple areas and some lighter purple areas. And then there's a whole lot of purple dit dots. We can see some blood vessels as well. So this is kind of consistent with an inflamed conjunctival substantia propria. And when we go higher mag, we see a lot of that basophilic stuff. And actually, there are two different flavors, I thought, in this sample. So one of the flavors, and by flavors, I mean morphology. So here we have sort of basophilic, kind of chunky, irregular, crystalline. You can see how it's kind of shattering as it's getting sectioned, or it was shattered as it was sectioned. And then what is consistent for a lot of the mineralized stuff in this sample is that we have a lot of macrophages here surrounding it. Some of them are multinucleated. Some of them, we can find some multinucleated cells with smaller fragments of this mineralized stuff in their tummies. So we've got a quite active sort of granulomatous response to this mineral. So the other morphology of the mineral is kind of more common than that, I thought. And it's this much more finely fibrillar mineral sort of pattern here. So I almost wondered if this was mineralization of the collagen of the substantia propria. Like here's a nice example where it's just really finely fibrillar. So it's some sort of probably dystrophic mineralization, I think. And we also have a mixed bag of inflammation here. There might be a few neutrophils, some lymphocytes, and some plasma cells. So these are the main findings of this case. Here is an area where it's almost more coarsely chunky again. I maybe significantly did, oh, look at that beautiful giant cell. It's so pretty. Look at that. Anyway, is that a Teuton giant cell? I'm not sure. Anyway, so I did not find a population of eosinophils in this there. Here's a giant multinucleate giant cell with mineral in its tummy. But anyway, so this is just there's not a whole lot more to describe here, but I just thought this was really interesting and I pondered it. I ended up going down a PubMed rabbit hole, trying to figure out what this could be and in relation to the maggots in particular. So, my diagnosis was marked mineral accumulation with associated granulomatous, lymphoplasmacytic, and neutrophilic conjunctivitis, and mild epithelial hyperplasia that was idiopathic. So I jumped down the rabbit hole, and there's this whole diagnosis in human medicine called ophthalmia nodosa, which seems to be reserved for when humans get various arthropod bits stuck to their corneal in their corneal stroma or in their conjunctival substantia propria. And this includes things most notably tarantula setae, which is often associated with pet tarantulas. And also
Tarantula crawl on your face.
yeah, and also caterpillar setae. I didn't find any specific ones about maggots, but I kind of can imagine that perhaps if you have a bunch of maggots in your eyes and maybe some of them don't survive to adulthood, that they're going to degenerate and maybe their little setae, their little spines will get stuck in your conjunctival substantia propria. But it was interesting that none of those things really, any of those mineralized accumulations looked like arthropod bits to me. I mean, a lot of arthropod stuff is often brownish and refractile, with little spikes on it. And I didn't see any of that in what we had there, but that was my best guess about what happened here. Anyone else have any other thoughts?
Some of the linear stuff looked like mineralized extracellular matrix, like collagen.
Yeah.
It's much finer than I'd expect for elastin, which would be like, if it was metastatic, I would expect it to be elastin first.
Okay.
One of the things, if you spread out and consider steroid use in general, is calcinosis cutis.
I did think about that as well, but then I was like, but they started treating it with steroids because of a problem. So the question is, I guess, did the steroids make it worse? And I did vaguely think about that, but I think I forgot to put that in my comment. Yeah, anyway, so I just thought it was kind of a cool case.
Dr. Lee
And-
said,
I
what are
really were maggots
maggots?
and not tent caterpillars.
I don't know. I mean, hopefully they can tell the difference between those two things.
Yeah, Dr. Lee said kind of similar. Never heard of maggots in a viable eye? Question mark.
Yeah, that's what I was confused with. I was actually really surprised that they were able to save the cat's
Yeah.
eyes. When I first started looking at the case, I'm like, oh, okay, well, anyway, yeah, so
News to me too.
Maybe like
Maybe-
bots, like something different.
yeah, right.
Or a bot fly or that.
Yeah.
Pennsylvania, though.
They probably weren't screw worms. Let's hope,
So
because it still has its eyes and its face. Anyway, cool. All right.
Jeez.
Thanks, everyone. Thanks for your attention.
cases.
Thanks everyone out there. We'll see you in 2 weeks.
Where that came back to me at a conference where somebody